Thank you very much, and good morning, everyone. So these are the objectives of my presentations today. I will review the most updated evidence and supporting the clinical applications of current therapies for patients with aneurysmal subarachnoid hemorrhage, and I'll provide you with some recommendation for management of this disease, which is often a catastrophic, devastating event. A few numbers here illustrate the scope of the problem. The mortality is pretty high, approaching 50%. The long-term disability is also high, affecting about 50% of survivors. And the poor outcome can be predicted by the initial severity of the bleeding, initial clinical severity, which can and should be assessed by means of one of these two validated clinical scales, the Hunt-NS grading scale and the World Federation Neurological Surgeon grading scale, where a score of 4 and 5 signifies poor clinical status and is associated with higher mortality and also higher disability, higher morbidity. Now, if you look at the causes of early mortality after subarachnoid hemorrhage among patients who reach the hospital alive, those are represented by rebleeding, delayed cerebral ischemia, hydrocephalus, ICP elevation, and cardiac complications. And so those are the focus of our neuro-ICU management. In particular, the earliest concern is limiting acute brain injury from ICP elevation, which may be secondary to hydrocephalus, of diffuse cerebral edema in the most severe cases. At the same time, we need to think about rebleeding of the unsecured aneurysm. And so here is a clinical case, an example. A 52-year-old male is transferred to your ICU. The CT scan shows subarachnoid hemorrhage. The patient is in coma, and so he's a poor grade Hunt-NS 5 patient. And you can see the CT scan, aside from subarachnoid hemorrhage, is showing you ventricular dilation. That is hydrocephalus, which we know can occur in up to 30% of these patients early on or later in the course, because the fact that subarachnoid hemorrhage, the blood, may interfere with the circulation of CSF within the ventricular system or with the resorption CSF at the level of the arachnoid granulation. And so here the priority is to insert an external ventricular drainage. This can be life-saving and can also lead to a dramatic clinical response, such as recovery of consciousness, also in poor grade patients. At the same time, your other concern, major concern, is preventing rebleeding. We do know that unsecured aneurysm tends to rebleed, especially during the first 24 hours. 4% is the maximal frequency, and the risk is highest in the first 6 hours. And rebleeding has catastrophic effects. The mortality is pretty high, almost 80%, and the odds of survival without disability are really reduced. Now, there are a number of things that we can do to prevent this outcome. Obviously, early aneurysm repair is the most effective therapy, and this can be accomplished via microsurgical clipping or endovascular coiling. Either technique has good results and low rate of complication in skillful hands, unless we are dealing with large or giant aneurysms. Obviously, endovascular coiling is more appealing because it's a less invasive procedure, but not all the aneurysms are amenable to this intervention. So there are certain anatomical factors that needs to be satisfied. But if an aneurysm is amenable to either technique, what should we do? Should we coil them or should we clip them? And so this has been long debated. Two major studies, two randomized controlled trials, the ISAT and the more recent Barrow rupture aneurysm trial, the BRAT trial, have addressed this question. The ISAT enrolled more than 2,000 patients, patients for whom either treatment was deemed appropriate, either coiling or clipping. Most of these patients had a good clinical status upon presentation. Most of the aneurysms were in the anterior circulation. And you can see that follow-up data shows that compared to clipping, coiling is associated with better functional outcome, less disability at 1 year, with an absolute risk reduction for poor outcome of 7.4%. There was also lower prevalence of epilepsy and cognitive decline in 1 year in this patient. However, there was also a slightly higher rate of late rebleeding due to aneurysm regrowth. However, the risk for late rebleeding was overall small with either therapy, and certainly outweighed by the benefit in morbidity reduction. However, these trials received several criticisms, mainly because of the small percentage of patients that were randomized, because the study, again, was designed to enroll only patients for whom either treatment was appropriate. And so this has called into question whether the study population really reflect the general population with rupture intracranial aneurysm. So to address the shortcomings, another trial was conducted and initially published, the results were initially published in 2012, the BRAD trial. And this study confirmed the results of ISAT at 1 year. You get fewer poor outcomes described by a modified ranking scores above 2. So that means like some disability at 1 year with coiling. Severe disability is 4, very severe disability is 5. However, follow-up data published in 2013 at 3 years shows that really there was actually no significant difference in the incidence of poor outcome between groups for anterior circulation aneurysm. They really did the same in both groups in terms of disability. However, there was significant benefit in clinical outcomes from coiling of posterior circulation aneurysm. And so the authors concluded that possibly there is a better clinical outcome from coiling of posterior circulation aneurysm. However, they also noted that clipping in either group resulted in a significantly better degree of aneurysm obliteration, 87% with clipping versus 52% with coiling, and also a decreased rate of aneurysm retreatment, 5% versus 13%. And so the authors conclude that perhaps clipping is the preferable management strategy for anterior circulation aneurysm. But the jury is still out on this. Certainly we can state that decision needs to be made by a team of experienced neurosurgeons and neurointerventionalists. The skills of the treating physician, interventionalist, and neurosurgeon have a great impact on the outcome. And we cannot treat all patients with one modality without considering anatomical and clinical and other factors. But we can certainly say that coiling, if the aneurysm meets certain anatomical criteria like this one, the dome to neck ratio above 2, the neck width less than 3, then coiling should be favored over clipping for posterior circulation aneurysm, which are more difficult to address surgically, and also for patients with poor clinical status or several comorbidities, so advanced aged. Those patients may fare better with coiling. And it's important also this criterion: the patient doesn't have to have any hematoma requiring surgical decompression. How about timing? There's no doubt the early treatment, which means within 72 hours, better within 24 hours. Early treatment on the aneurysm is the standard of care for good grade patient, HANTES 1 to 3, because it can reduce the rate of rebleeding, which we said is very high in the first day. And also it will allow aggressive treatment of vasospasm. But for poor grade patients, the timing of treatment is controversial. Overall temporal prognosis tends to be poor. Treatment decision needs to be individualized in this population. But if the aneurysm is amenable to coiling, then early coiling should be favored over clipping. If that's not the case, then delaying clipping for about 10 days in order to allow the brain edema to subside and thus thereby allowing safe surgery is recommended. What else can we do to prevent rebleeding? Certainly blood pressure control. Before securing the aneurysm, we need to keep the blood pressure low. Now, we don't have a defined blood pressure target, but the 2012 American Stroke Association guidelines tell us that a systolic blood pressure goal less than 160 is reasonable. And so there is class 2A level of evidence C for this recommendation. So it's a recommendation based on a paucity of data, including this study here, which was a retrospective chart reviews of more than 500 patients that identifies systolic blood pressure above 160 as one of the most common pre-existing factors before rupture of the aneurysm. And these prospective studies involving more than 200 patients that identified again a systolic blood pressure above 160 as the risk factor, independent risk factor for pre-hospitalization rebleeding. So really a positive data. And so many neurosurgeons and many neurointensivists feel more comfortable with a systolic blood pressure goal below 140, sometimes below 120 before securing the aneurysm. Now this is reasonable. However, you got to keep in mind that in poor grade subarachnoid hemorrhage patient, excessive blood pressure lowering has been associated with an increased risk of ischemia, and there is evidence from these studies published in 2011 focusing on poor grade patients that underwent a multimodality neuromonitoring in the form of brain tissue oxygen tension monitoring or microdialysis, which is a technique to look at metabolism on the brain cells. This study showed that when you drop the blood pressure to the point that the CPP, the cerebral perfusion pressure, falls below 70, then you have a lot of metabolic crisis, a lot of ischemia. Markers of ischemia go up, and the brain tissue oxygen level goes down. So keep that in mind. What we do is in good grade patient, we tend to be more aggressive. We keep the blood pressure, systolic blood pressure below 140, and in poor grade patient, we tend to adopt the higher threshold so that the CPP remains around 70. Antifibrinolytic therapy has also been proposed as a way to reduce rebleeding. Again, there's no established role for this therapy, but the use of this agent, tranexamic acid, aminocaproic acid, has been shown, according to Cochrane database review, to reduce the risk of bleeding significantly by 35%, although there was no impact on outcome. And this is because the risk of the bleeding was somehow offset by the increased risk of cerebral ischemia when therapy was prolonged for more than 72 hours. So we can consider this therapy. The guidelines, current guidelines tell us it's reasonable to use it for no more than 72 hours anytime the patient cannot undergo clipping and annealing in a timely manner, but not beyond 72 hours. How about delayed cerebral ischemia once you have stabilized the patient? The other major concern is essentially, the major focus is preventing, detecting, and treating delayed cerebral ischemia, which is defined as a new focal neurological deficit and or deterioration in level of consciousness lasting more than 1 hour with or without neuroimaging evidence of a new infarction. And the risk for this complication starts around day 3 after the bleeding, peaks around day 5, 7, and ends around day 14, 21. Now, DCI kind of replaced the old terminology of clinical vasospasm. It has been found to be a more clinically relevant definition because terms like symptomatic vasospasm implies that the clinical feature of ischemia are present in combination with angiographic evidence of vasospasm. But we do know that is not the case. Many patients with angiographic vasospasms have no DCI. They do not develop any ischemic deficit. Some patients with DCI have no angiographic vasospasm. And that tells us that there are likely mechanisms independent of large vessel vasospasm that cause secondary ischemic brain injury in this patient. And so until the exact pathogenesis of DCI is not completely understood, we better adopt this uniform definition that describes the whole clinical picture without making any assumption on the underlying pathogenesis. This definition may facilitate comparisons of studies and may facilitate also understanding of the true impact of an intervention, a neuroprotective intervention. So how do we monitor for DCI? If you are dealing with a good grade patient, the most essential tool is this one, frequent neurological examination, supplemented by daily TCD, transcranial Doppler ultrasound, which is a poor man's angiography, where an increase in mean flow velocities becomes a surrogate measures of arterial narrowing. However, keep in mind that TCDs, although has the advantages of being not invasive, it is not sufficiently sensitive or specific. I mean, data are good, are best for MCA, and that's about it. For MCA, a value of velocity, mean flow velocity below 120 can reliably indicate absence of vasospasm. A value above 200 can reliably indicate presence of vasospasm. But values between these two extremes are of uncertain significance. And so they always require confirmatory tests. The Linegar index has been used to correct for possible hyperemia, which is a confounding factor. Hyperemia can cause an increase in mean flow velocities, and may be secondary to hypervolemia, may be secondary to anemia, may be secondary to fever, which is very common. And so the ratio between MCA and extracranial ICA is used to differentiate this condition. A value above 6 is definitely suggestive of presence of vasospasm. Value below that are of uncertain significance. It's very important also to look at dynamic changes rather than absolute values. If there is a twofold increase compared to the previous day, then that's strongly predictive of vasospasm. But in any case, if vasospasm is suspected, you will need to request confirmatory test. You can obtain the conventional 4-vessel angiography, which is the gold standard but invasive, or you can choose these two non-invasive alternatives, where the only disadvantage is contrast load, the radiation exposure, but they do have good correlation with angiography. Now, CT perfusion in particular is able to quantify cerebral perfusion parameters such as cerebral blood flow and mean transit time, and also cerebral blood volume. When we look for vasospasm, we are more interested in this one, CBF and CBV. You can see here this LACO red in the posterior territories means decreased CBF. And this LACO yellow here in the posterior territories that mirror this means slow blood flow, prolonged mean transit time. This is very specific for vasospasm. This is very sensitive for vasospasm. And here the angiography confirms, in this case, a severe vasospasm in basilar artery. If you are dealing with a poor grade subarachnoid hemorrhage patient, then you may need to resort to other tools in advanced neuro ICU, where multimodality neuromonitoring expertise is available. We sometimes use partial brain tissue PO monitoring to detect brain tissue hypoxia below 10, which has been shown to correlate well with infarction. Sometimes we use microdialysis to look for an increase in glycerol, glutamate, LPR. All these are markers of ischemia which correlate well with CBF reduction documented on PET scan. And again, you can, several others have suggested CTA, CTP as a screening tools for perfusion deficit in this patient in whom you cannot follow the neuro exam. How do we prevent vasospasm? Just two simple measures, nimodipine and normovolemia. Now, nimodipine finds strong support from a multi-center randomized controlled trial and several meta-analyses, all showing that this drug does improve outcome by reducing the risk of ischemia. It does not affect angiographic vasospasm. So nimodipine does not prevent vasospasm. Nevertheless, remains neuroprotective through other mechanisms not completely understood. And then this one, this is really important, euvolemia. We do know hypovolemia is bad for this patient. And so it's very important to pay meticulous attention to the daily fluid balance. It's very simple. You got to account for insensible losses. Always keep that in mind, which are about 500, 800 cc per day, unless the patient has fever. And you gotta replace, so really euvolemia means a daily positive fluid balance of 500, 800 cc. That's not hypervolemia. That's normovolemia when you account for insensible losses. At a minimum, most patients will need 125 ml per hour normal saline to keep up with the losses. Never use fluid restriction if you have hyponatremia. We'll talk about this later. But if normovolemia is a must, prophylactic hypervolemia, on the contrary, is not useful. And several studies have shown that, including this small randomized trial, that show that if you administer a lot of fluids to keep the CVP high, in the end, the patients have the same fluid balance because they are working kidneys, so they will excrete everything, and there will be no effect on cerebral blood flow or outcome. And if the patient doesn't have working kidneys, then this is bad because they will end up with pulmonary edema. So don't do prophylactic hypervolemia, do normovolemia by that guidance. So what did not work aside from prophylactic hypervolemia in the prevention of DCI? Clazosentan didn't work. This was an endothelin receptor antagonist that was addressed, its role was addressed in the CONSCIOUS 2 multi-center randomized controlled trial as to counteract the action of endothelin 1, which is a potent vasoconstrictor implicated in the onset of vasospasm. The study was a large study, did not find any impact on outcome, although it did find that this drug has an effect on angiographic vasospasm. Magnesium is another failure somehow. Magnesium is a calcium antagonist and also an MDA receptor antagonist. Those actions are independent from each other, and so could be vasodilator and neuroprotectant. And we do know hypomagnesemia, having a low magnesium, is a predictor of vasospasm. And there were several animal studies and a phase 2 study showing that in subarachnoid hemorrhage, magnesium infusion could decrease DCI. However, 2 large phase 3 trials, the MASH2 is really the large one, and high MASH that preceded it, found no benefit. So there's no current evidence to support routine induction of hypermagnesemia. Don't do it, but pay attention every day to the level of magnesium. If it's low, replete that. Statins didn't work either. Again, they were found to be safe in subarachnoid hemorrhage, but really mixed results in terms of outcome benefit from previous studies. The largest trial was the STASH trial published in 2014 that randomized more than 800 patients to the drug versus placebo. Again, no benefit. You can see at this graph here the proportion of modified Rankin scores were similar in both groups. So really safe, but if you look at this square here, at this diamond here, no effect at all. Other approach under investigation, intrathecal thrombolysis. The idea is to clear the blood in the subarachnoid space, which has been shown to correlate with the risk of vasospasm. We need a definitive trial to answer the question of whether this is effective or not. About management, once the DCI has developed, those are your weapons: hyperdynamic therapy and endovascular therapy. Now, hyperdynamic therapy, we have moved away from the traditional Triple H therapy, hemodilution, hypervolemia, hypertension. We don't care about the first 2 H. We just focus on hypertension with maintenance of euvolemia. And there is class 2A level B evidence to support this. Some authors suggest cardiac output augmentation with dobutamine or milrinone if induced hypertension is not sufficient to achieve an amelioration in ischemic deficit. But if this hyperdynamic therapy does not resolve the issue, then you gotta resort to endovascular therapy in the form of intraarterial vasodilators such as verapamil, nicardipine. They have rapid onset but short action, so they may require multiple treatments. And a more durable solution is transluminal cerebral angioplasty, which can be used only for focal vasospasm or large vessel, M1, P1, A1, DCA. It's durable, but there is up to 10% risk of major complications such as vessel rupture and dissection. Here, just a few comments on induced hypertension, how you have to implement it. Well, we don't have a defined blood pressure endpoints. If you look at several studies, look at the literature, several studies have come up with different targets. But there is a consensus that initial MAP elevation by 20–35% is a good starting point. And then you should assess the patient, follow up the patient with periodic neurological exam to see if the blood pressure goal is sufficient to resolve the issue. If not, you keep going up in a stepwise manner until you get to maximum 200, 220, or 150 on MAP. If you're giving nimodipine and nimodipine leads to drop in blood pressure, change dosing interval to more frequent lower dose. Rather than 60 Q4, go 30 Q2, and if you still see that the blood pressure drops, stop the drug. Seizures are not so common, but can affect up to 7% of patients at onset. When they do occur, they may result in rebleeding, and so the consensus is that anticonvulsant therapy is beneficial in this patient, but you should give it only for a short period, 3-7 days, until the aneurysm is secured, unless you have acute seizure, in which case you may consider continuation of therapy for 6 months. Now, don't use phenytoin because this worsened functional outcome is no longer recommended. Keppra is a good drug. Keep in mind that non-convulsive seizure may occur in up to 90% of patients and may confound exam, may be contributor to coma, and so continuous EEG is recommended, and we actually do perform it in poor grade subarachnoid hemorrhage patients when other causes for the deterioration are not evident. Hyponatremia is very common after subarachnoid hemorrhage, and it's usually secondary to either SIDH or cerebral West syndrome, which in turn is secondary to release of this brain natriuretic peptide that causes natriuresis. So there's no way to differentiate these two conditions. If you look at, if you obtain the classics lab study, urine sodium, urine osmolarity, and serum uric acid, they are all the same in either condition. What you need to look at is the fluid balance. If you have negative fluid balance, that's cerebral West syndrome. If you have positive even fluid balance, you're dealing with SIDH. So how do you treat it? Don't fluid restrict. You can free water restrict, but you gotta make it up for with a lot of IV fluids in the form of normal saline or 3% saline if the hyponatremia is severe or refractory, and add oral salt tablets, 2-3 grams Q6, 8 hours is really helpful. And if there is evidence of persistent negative fluid balance, diuresis, which happens with cerebral West syndrome, add fludrocortisone acetate to promote sodium and water retention. Fever is really bad for any acute brain injury, stroke, hemorrhagic, ischemic, traumatic brain injury, spinal cord injury, subarachnoid hemorrhage. Increase the risk of symptomatic vasospasm, increase the chance of poor outcome. There is several evidence from small studies, including these case control studies, that normothermia, which we define as a temperature below 37.5, better around 37, should be the target for at least the first 2 weeks after subarachnoid hemorrhage. You may achieve a better outcome. And you can use antipyretics or surface cooling or intravascular device if this doesn't work. And finally, neurogenic stunned myocardium. It's a complication you may encounter in poor grade subarachnoid hemorrhage patients, usually women in their middle age. We're dealing here with a reversible but acute left ventricular systolic and diastolic dysfunction secondary to a catecholamine surge at the time of the bleeding that caused direct myocardial injury. This is manifest with hypotension due to reduced cardiac output. It's accompanied by a troponin elevation and ECG abnormalities, as well as regional wall motion abnormalities on echo that may mimic acute myocardial ischemia. And so this can be problematic to deal with this condition in the face of vasospasm because vasopressor will not work. You need inotropes. That's your first line. If your hypotension is refractory to dobutamine, then you may need to consider intra-aortic balloon pump counterpulsation to support the hemodynamics. And always resort to endovascular therapy early to treat vasospasm rather than relying on induced hypertension. If you had to differentiate MI from stunning, then this paper in 2008 provide you with an algorithm that places emphasis on the echo. If you have a regional wall motion abnormality in a single vascular territory, that's probably more consistent with MI. If you have a regional wall motion beyond single territory, then more consistent with stunning. You may want to repeat an echo in 1-2 weeks. If it's really stunning, you will see recovery. So in conclusion, keep systolic blood pressure less than under 60. With unsecured aneurysm, maybe less than under 40 is also acceptable in good grade patient. After secured aneurysm, let the blood pressure ride. This is permissive, not induced. You're not doing anything to increase the blood pressure, but let it ride up to 180, 200. Place an EVD anytime there is symptomatic hydrocephalus or poor grade patient. Keep the CPP around 70. Use nimodipine, aggressive fever control, normovolemia to prevent DCI. And if DCI has ensued, then use induced hypertension or inotropes and early use of endovascular therapy. Thank you very much.